Good morning, everyone. This morning we're going to speak about neuromodulation of the tibial nerve, and it's an overall review, and we're going to cover this in about the next 45 minutes and take questions at the end. Thank you, Jonah, for getting us set up, and welcome to everyone who has joined us on WebEx this morning. I've divided the talk into 7 smaller sections because it is a review, and I'm going to start with some definitions that are in the literature, and especially a few abbreviations that come up from time to time. And then I'm going to go back and review some of the historical relevant articles to neuromodulation. And I'm going to specifically pick out the articles that are related to tibial nerve as opposed to sacral nerve, which we talked about a couple of weeks ago. We're going to then review evidence for the mechanism of action, go over some of the anatomy related to the tibial nerve, indications, contraindications for the procedure, and then I'll review the current technique and briefly complications management, and then finally about 10-15 minutes at the end, I've done sort of a summary of the literature of current outcomes and clinical trials that have been recently reported. So posterior tibial nerve stimulation is the medical procedure where neuromodulation is performed on the posterior tibial nerve. It is abbreviated usually in the literature as PTNS. Percutaneous tibial nerve stimulation is the minimally invasive form of neuromodulation to the tibial nerve. It is also abbreviated in the literature PTNS. And so when we see PTNS written, we make the assumption actually that these two things are the same, percutaneous and posterior tibial nerve stimulation. We assume they're the same procedure and that they involve a needle, electrode, some sort of electrical source, and some sort of grounding position on the body. Transcutaneous posterior tibial nerve stimulation is usually abbreviated PTNS, and this is the non-invasive form of neuromodulation applied to the posterior tibial nerve using surface electrodes. So usually 2 surface electrodes, connectivity to an electrical source. The International Continence Society does not include a definition of neuromodulation, so we go to the general medical literature for this and the neurosurgical literature for this. Neuromodulation is the medical procedure used to alter nervous system function. It's a very general term. Electrical stimulation, which is part of what we are talking about today, can be used to target, of course, various regions in the nervous system. We use sacral nerve stimulation, we use peripheral, and we use transcutaneous, all falling under this same category. Neuromodulation also refers to any medicine that you put directly into the CSF to modulate a region of nerves within the body. It involves release of neurotransmitters that regulate this general population of CNS neurons. In other words, there's one neuron transmitting and connecting to several neurons, okay? Diffusion to a larger area and having an effect on multiple neurons, including acetylcholine, dopamine, serotonin, etc. A whole bunch of neuromodulators. This is not the same as direct synaptic transmission, and some people often write that it is in fact the exact opposite. Here you have one neuron connecting to one neuron. What we are talking about is neuron connecting to a whole region. So this is a concept, a relatively new concept, which is written about in the literature. So a neuromodulator can be a neurotransmitter, like we just reviewed several of them, and generally they are not reabsorbed by the presynaptic neuron or broken down, and what they do is they hang around. They hang around for a time and they influence or modulate nerves in the region. Thereby, some people would say with electrical stimulation, I mean, why do you need to give it 20 minutes, 30 minutes? And the idea is that it needs to be hanging around to neuromodulate the nerves in the region. In our case, the neuromodulator we're going to talk about is a specific electrical stimulus. So neuromodulation is contrasted to fast synaptic transmission, okay? And they differ on receptors that they act upon. Neuromodulation generally involves G protein-coupled receptors, and fast synaptic transmission often involves the voltage gate ion channels. We heard a little bit about the history of electrical stimulation a couple of weeks ago when we were talking about sacral nerve stimulation, and there is a long history in medicine about it. But many of the historical texts refer back to this guy, Scribonius Largus, who was the physician to Roman Emperor Claudius. He's a famous guy. He had a coin for himself and his name across the bottom, and he wrote down the first 245 prescriptions that he thought were important, some of which included targeting humans with various forms of fish that generated electrical current. We're going to talk specifically about the bladder now, and the electrical stimulation to enhance bladder storage does have a long history, principally dating back to the 1940s, 50s, and 60s. It has been used to describe treatment for urge incontinence, frequency, and even stress incontinence. Sacral anterior root stimulation and S3 neuromodulation have been previously evaluated, and we discussed them in our previous grand rounds. Peripherally, pudendal nerve stimulation, anal and vaginal stimulation, as well as surface stimulation in the perineal area have been reported on a whole bunch of areas of interest to us. Principally, we're going to focus on this area, urge incontinence and irritative symptoms, originally reported by Dr. McGuire, fecal continence, originally reported by Dr. Stoller, chronic pelvic pain, and even sexual dysfunction. There are some important notes before we go through these few historical articles. When we keep in mind sort of the general principle that every stimulator we use has certain common features. There's always, of course, the electrical source. This is generally a 9-volt battery within some sort of pack. You can use a needle or a surface electrode, so a needle or a surface electrode. There is always a generator. And then there are certain things which you may or may not have control of. The frequency of the electricity, the pulse width of the electricity, and grounding. Is the grounding on the patient? Is the grounding within the electrical source? So when we read about it, these are some of the things that will vary over time, depending on the hardware that is available. Well, most people refer back to this classic article, 1983, by Dr. McGuire, and it is often referred to as sort of the beginning of tibial nerve stimulation. The article was Treatment of Motor and Sensory Detrusor Instability, a term we don't use anymore, by electrical stimulation. So he used this treatment to treat motor bladder overactivity as well as sensory urgency. In his article, he had sort of a brief abstract at the beginning, and I'm just going to, bear with me, I'm going to read to you a few excerpts from this article because they're really very interesting. He said, this is a new application of electrical stimulation to inhibit detrusor overactivity, and he reported it in 15 patients. The 15 patients did not have idiopathic overactivity. They had neural lesions. He said the results were astonishingly good, okay, and that he was able to successfully treat the patients, and this included motor urgency as well as sensory urgency. The rationale he reported in 1983 was actually to access some of the same sacral nerve root areas that originated from the setting of Chinese acupuncture, dating back, of course, thousands of years. He has a couple of excerpts here that tell us about the history of what was going on at the time and how tibial nerve stimulation evolved. And I'm going to read to you just briefly a couple of these excerpts because I think it summarizes what was going on at the time. In the course of experimental studies on the inhibition of detrusor activity in non-human primates with spinal cord injury, we noted that bipolar anal sphincter stimulation was effective only if current was delivered by needle electrodes to the sphincter muscle. So at the time, there was a lot of work going on, primate research, and it was in the setting of various induced spinal cord injuries. Ultimately, he was able to modify the technique, and then we then found that current could be applied by a positive electrode transcutaneously, so not with a needle electrode, but transcutaneously to the common perineal or posterior tibial nerve with a grounding electrode placed over the contralateral common perineal or posterior tibial nerve with similar results. Okay, so this is very important because he was talking about transcutaneous stimulation and not needle stimulation. He also described here and summarized what we now know and carry on with today as the basic parameters that you require. Reproducible, effective inhibition of reflex detrusor activity required 5 to 8 volts, 2 to 10 cycles per second, and a pulse width of 5 to 20 milliseconds. Many of these features are still maintained in current devices that we use today. The working electrical energy in watts is minuscule. We sound like we're in outer space, Jonas. Okay. And the mean current draw in a stimulated nerve that results in detrusor inhibition is in the order of 50 to 100 microamps. So in other words, he was very focused on the potential loss of electrical current. Should it be needle? Should it be transcutaneous patches? He referred back to what is actually the original article about tibial nerve stimulation written in the Lancet in 1963 by Dr. Caldwell. And his article goes through and actually describes placing needles at the tibial nerve. And I thought this was so eloquent, his very first sentence of his paper. The sphincters are normally so adequate that one realizes their importance only when incompetence arises. It was sort of very succinct to the time. In the 1990s, Stothers, who became very famous, of course, reported in European Urology the use of what is more commonly known now today as the tibial nerve stimulator with a needle electrode. It was use of a 34-gauge needle, 3 finger breadths above the medial malleolus, using disposable, self-adhesive grounding electrodes. So the grounding was not within the device, but was to the patient. And so an example of such a device. So we're now in the 1990s and coming into 2000. So percutaneous stimulation was described then by Stothers. The technique was originally invented at the University of Iowa, and they developed a commercial firm called Urologic. This company originally received FDA approval in 2000. The company subsequently closed, and we went on to have other stimulators, which we now use today. In 2003, there was a resurgence of the idea that you could deliver the electricity through transcutaneous patches on the skin without needles. And a very important article about this is by Andrews, who described this actually in the spinal cord injured population. Here's an example of his article, and I just want to show you a little bit better enlargement of this photo. So here we've got transcutaneous patches on the patient bilaterally in a spinal cord injured patient using a stimulator of which you actually had control of many of these different aspects, frequency, pulse width, etc., some of which are now fixed in different sources that we use today of electricity. So 2005, the FDA approved the Urgent PC stimulator, which has gone through several modifications. This was the first one that I used myself and had contact with patients. Some important features of this is that there was the battery pack, And then there was this whole assembly, which is your electrical wire, your grounding patch, your needle, the ability to have adhesion to the patient. All of this was in one piece and was not sort of in separate pieces. Here it is attached to the patient, grounding patch, and I'm placing the needle, and here's the source going back to the electrical stimulator. So a disadvantage of this setup was actually that this thing was all in one great big piece. If you had contamination of the needle fell out, you had to replace this whole section. This is now changed with our more current device, and we'll go through and show you that in a moment. Here's our current device that we use, the tibial nerve stimulator, the current version of the Urgent PC. There are lots of different transcutaneous stimulators. Patients often buy them off the internet. I mean, here I put only one example. This one is from Schwab Medical, but there are many examples, and they all have different settings in them. So it's important when you buy them to know what settings they have, what's fixed, and what's flexible. What do you have control over? The potential mechanism of action of tibial nerve stimulation has two articles which go back and describe it in quite detail, one of which is in Neurourology and Neurodynamics. PTNS inhibits bladder activity by depolarizing somatic sacral and lumbar afferent fibers, and that it centrally inhibits preganglionic bladder motor neurons directly through the sacral cord. And these articles are in quite a bit of detail and use urodynamic data to back up some of their statements. So an example would be something like this. Here's one of the article segments from Journal of Urology showing a patient during filling with reflex bladder overactivity, and then the same patient, their detrusor pressure during PTNS stimulation, showing the delay prior to reflex activity. So this is during stimulation, and the patient has their own control without stimulation. So let's review a few features of the anatomy. The tibial nerve is the medial terminal branch of the sciatic nerve, originating at the lumbar and sacral level, and it has motor and sensory elements. So here is the big giant trunk of the sciatic nerve, all of the unshaded part being the tibial segment, and we've got branches here, S3, S2, then the S1, and then your lumbars, L4 and L5 contributing. The nerve travels down, of course, the back, you can trace it down. McGuire accessed it sometimes at this location, branches here. But we are interested, of course, in the nerve way farther down at the level of the ankle. And there is the old medical school adage for the anatomy, Tom, Dick, and Harry, referring to, for Tom, tibialis posterior, Dick being flexor digitorum, which is our main landmark, and for the artery, the nerve, and then finally flexor hallucis longus being for Harry. And it's stimulation in the region of these muscles that you get your known flexion of the foot, splaying of the toes, which tells you that you're in the right region. And so we use surface landmarks generally in order to find the correct location. The indications for PTNS are generally related to overactive bladder. So we're talking frequency, urgency, urgent continence. However, there are indications also related to overactive bowel and incontinence of stool. We know lots about the history and the effects of urinary incontinence, but just a single slide as a reminder. Fecal incontinence, 10% lifetime risk. Similar social, economic, quality of life implications that we have to urinary incontinence. Affects approximately 4% of women after vaginal delivery, and 30% of women have some sort of anal sphincter trauma related with vaginal delivery. So the problem is relatively common in our community. So when do we not do PTNS? We don't do it in patients with pacemakers or any sort of implanted defibrillator. You can't use any anticoagulants. Patients with bleeding tendency, obviously you have a needle in place for 30 minutes stimulating. It's not done in pregnancy, and there are certain skin disorders of the ankle. You need to be able to place the needle in an area of the ankle where the skin is intact. Before you start treatment, you might want to complete something like Canadian Urologic Association voiding diary. Generally, patients have a cystoscopy. We check their medicine list. We have a look at their ankle. I look to see if they've had prior surgery. Do they have any hardware in their ankle, say from ankle fracture? We give them information about the procedure, and then we give them very important small reminder, no lotions or potions on your feet. You need to be able to have the grounding electrodes stick well in order to get good contact and have good stimulation. If the patient has bowel dysfunction, they might complete the Wexner score, and this would be a validated score similar to things that we would use for urinary incontinence, talking about types of incontinence, use of pads, and then the frequency of the loss, either solid, liquid, gas, etc. So 0, of course, you're perfect, and if you get a score up to 20, 20 represents complete incontinence. So on the day of treatment, you're going to position the patient. I usually have the patient lie down with the head of the bed elevated with the legs outstretched in a straight line. Originally, a lot of people described using the patient, putting them in a frog leg position. I have found that it's hard for patients to maintain this frog leg position for 30 minutes, and that sometimes they may move their legs, and in doing so, they can dislodge the needle. So I usually put them with the legs outstretched. It is also described that you can recline the patient in a chair with the foot elevated. You obviously remove their shoes and socks, and you double check the condition of the skin before you place the needle. You're going to open up your slide pack, and what does it have in it? It's going to have your stimulator, of course, on the side, and then a number of components. And we're going to use the urgent PC stimulator, and it has some fixed parameters, and it also has adjustable stimulation intensity. So it looks something like this. There's the pack. We're going to open up the contents of the pack. We've got a couple of needles, alcohol swab, and here is your electrical contacts grounding patch. The needle comes with a small plastic device in the top, and when this device is in the top, the needle is held above the base of the plastic outside tubing, such that you can place this against the patient, remove the plastic top, the needle falls down, makes contact with the patient's skin, so that you can touch the top of this needle and place the needle in to the patient in a more accurate fashion, and then of course you remove the sheath. You look for flexion of the great toe or fanning of toes to help you know you're in the right region, and you might get a sensory response under the sole of the foot. So again, we want to be up in this region. We don't want to be placing down in this region. When we get down here, we get pain and we don't get the right effect that we're looking for. We can, of course, see the tibial nerve, artery, and vein with ultrasound. If someone had a lot of peripheral edema, you may be able to do this to help you to localize it. And of course, the Doppler beautifully always shows this neurovascular bundle. So it's really easy to see, even in patients who have peripheral edema. To make contact here, this is the tubing in the resting position, and then you squeeze this, and this delivers the little hook electrode, which you're going to attach directly to the needle to the patient. So this is different than the older setup I showed you, where this thing was all in one segment, and this was actually all part of one component. You're going to stimulate the patient for about 30 minutes, and the patient can either read or rest during this time. And it's important to check on the patient during the 30 minutes of stimulation to confirm your needle placement. Patients can move their feet around, they can drop a foot off the edge of the table. I mean, the needle can become displaced. So it's important to just periodically, you need to check on them and check for placement. The complications are said in the literature to be relatively few, and many articles say there are none, no complications, none. In reading things, you can come up with, and you see clinically, some of these things occur. Not commonly, but they are things to think about. Local pain or discomfort. You might have the stimulator turned up too high. You might not have the correct needle placement. It is possible and has been reported to have bleeding or hematoma formation. If you hit the tibial artery, you remove the needle, you put surface pressure, and this is usually all that is required. Some patients do get a form of sort of abdominal pain, and this has been seen in some patients who've been stimulated with various forms of true spinal cord injury. Infection at the needle site is really, really rare, and I did read only one report of this. Some patients do get some tingling or sensory awareness around the area of the needle. Dermatitis from the grounding patch I've seen on one occasion, and on one occasion I've seen pain related to previous ankle surgery where the patient actually had a piece of hardware still in their ankle that they weren't aware of. So let's go into the last 10 minutes of the talk a little bit about some of the outcomes of tibial nerve stimulation. So just briefly, looking at the technique, most authors report that they use 12 initial treatments. So this is McGuire's original article, Fred Govier's article we're going to look at in a minute, but most people use 12 treatments, most of them spread out on a weekly basis. Some authors take 12 treatments and squeeze them into a month, into 4 weeks, and others have looked at reduced treatment cycles, 6 cycles, 8 cycles, and these last few articles I'm going to pull out and we're going to sort of look at them one by one. The outcome overall, when you look at it, many of the authors use the same definition actually of outcome as being successful, and they look for a 50% reduction in incontinence episodes based on a 3-day voiding diary. And when that occurs, they classify the patient as being successful, and then they use that to calculate their outcome. So most authors actually report in the range of 2/3 to 3/4 of patients having a greater than 50% reduction in incontinence episodes when we're talking about the bladder. This is Fred Govier's article, and it's important. It came out sort of related at the timing, related to further FDA approvals. There were 53 subjects. This was the first sort of small multi-center trial. It involved Fred in Seattle, Vic Nitti, also in New York. And what they did is they did a 12-week cycle in patients. They used a voiding diary, and they found that they were able to classify, again, about 3/4 of their patients had a successful long-term outcome based on their voiding diary and counting up the numbers of episodes. They did get some positive improvement also that they felt was statistically significant in the way of reduction of pain. So patients who had overactive tight bladder symptoms but had also an element of painful bladder symptoms. So that was an important measurement from the time from 2001. There are a few very important randomized trials that have come out recently on the subject, and I'm going to just pull those out now and review those one by one. This article by Peters, very important, from the Journal of Urology 2010, is a randomized trial of the subject versus sham. And there were 220 adults enrolled, and they were randomized to either 12 weekly treatments of PTNS or to a sham procedure. So you could place the needle, you could place everything on the patient, but not actually stimulate the patient. And they did quality of life scores, a 3-day voiding diary, both at baseline and at the end of their 12-week cycle. And what they found was that the pain, yeah, and it is, that's one of the things I think that's interesting to talk about with this technique, is because you can actually create a situation where the patient can be relatively, blinded to what's going on, as opposed to trying to do something like sacral nerve stimulation, where you're doing obviously a surgical implant. So that's a completely different kind of story. So this and a couple of these other studies were important because they were able to create a sham effect. And they found 54% positive outcome for PTNS versus a 20% sham rate. So they had, statistically significant improvements on their global assessment tool, which was, that was a very important finding. And so this was a very important article for this reason. Fecal incontinence also has gained, the treatment's been gaining popularity for the treatment of this, and there are a number of small trials, some of them very recent, principally 8 studies between 2003 and 2010. These, however, have much smaller numbers, they have varying workup, and there are some differences in the technique. But again, when you use the Wexner score and other validated scores, there's actually a similar, 2/3 to 3/4 good response using some of these standardized outcome measures. Now, the treatment of fecal incontinence, the most important article is, I think, probably by Shafiq. This one is from 2003 because it was an article which also included a sham arm. So we've got one article for sham that's been done with the bladder, and another article using sham in the area of fecal incontinence, finding, again, in this case, 80%, greater than 50% reduction in incontinence episodes. So there are a number of studies that have looked at very specific aspects of outcome, and I'm going to go through and show you these sort of one at a time, going through how long should we treat the patient, up to some of the economic studies that have been done. So what about the length of the initial treatment? Conventionally, it's 12 weeks. There has been a study in BJU recently, 2010, which looked at trying to contract and shorten the initial treatment schedule down to 6 weeks. And they found that they had a good 70% response on their validated questionnaires at 6 weeks, and they basically suggested that the initial treatment cycle, you may be able to shorten and have it be shorter perhaps than 12 weeks. This was a suggestion. Do you need to do maintenance treatment? So you treat the patient, and do you need to keep going on and treating the patient after this? So this was addressed in an article 2006 in BJU. This is a very small number of patients. What they did, though, is they treated the patients for 6 weeks, they paused for 6 weeks, then they retreated the patients for 6 weeks. And they found that they had a significant decline during the time that they paused. So they concluded that you actually had to provide initially continuous therapy, that you shouldn't pause in the middle of a cycle. This treatment has been compared in a couple of articles to pharmacotherapy, and in 2009, Peter's article, randomized trial of percutaneous tibial nerve stimulation versus the extended release formulation of tolterodine. They randomized 100 patients to 12 weeks of PTNS or 4 milligrams of extended release tolterodine. They looked at the global response assessment, and that was actually in favor of percutaneous tibial nerve stimulation over tolterodine. It was hypothesized that this difference could be related to some of the side effects that patients experience when they take oral anticholinergic agents, dry mouth, etc. They had no difference in actual number of incontinence episodes during treatment when they compared these two treatments. So the improvement in incontinence was the same between the two arms. What was different was actually the global response assessment, which looked at domains that go sort of outside of traditional bladder measurements. Also, we've looked at the long-term durability of the treatment. And again, so this is an extension of that previous article that I've just described to you, where we had 100 subjects randomized to PTNS or 4 milligrams of extended release tolterodine. And after 12 weeks, the PTNS patients got offered an additional 9 months of maintenance therapy. And the purpose of this was to measure the outcome in those patients longer after they had been on maintenance therapy. And again, they looked at the global response assessment, and they did the 3-day avoiding diaries. So of those original patients, there were 50, there were 33 responders, and 25 of those were able to complete 12 months of therapy. So in this group, they had maintained their global response improvement and basically had maintained their reduction in urge incontinence episodes over the course of a year. There are a couple of studies which have used urodynamics during PTNS, and this is an example of one of them from 2003. And this was important because, again, it demonstrated that during PTNS, you could affect the urodynamic measurement by changing the volume that the patient was able to store, their maximum capacity, and time to first overactive bladder contraction. There are a couple of special populations before we close I'm just going to touch upon. There is a very recent trial on multiple sclerosis patients using transcutaneous PTNS, so non-needle surface electrodes, patients being treated at home daily for 20 minutes a day over 3 months using voiding diaries again, and they showed, interestingly, 82% of patients had a greater than 50% response. And there were urodynamic studies done during this trial to sort of substantiate these observations that they had from their clinical measures. Older patients, women over the age of 60, randomized trial, again, transcutaneous tibial nerve stimulation. They found that they were actually able to have a good response in this group. And what they did is they took traditional therapy for the patients. So they did all the patients enrolled had 12 weeks of bladder retraining, add pelvic floor muscle exercise programs, and then they randomized a group after standard therapy and gave them additional transcutaneous tibial nerve stimulation, and ultimately compared traditional to adding something to traditional. And they found in favor of adding to traditional with a statistically significant difference between these two groups. There are a couple of studies that address the use of the technique in children, and this is a very well-written article from 2011, Journal of Urology. It's out on EPUB, and it's a very nice review article. But essentially, in the end, it said that although PTNS has been studied in the pediatric population, it was tolerated, that there were really very few studies, mostly uncontrolled, and so they didn't come to any firm conclusion about the use in children. The article they refer to mostly is this article from Journal of Urology 2009, where there was 44 children who had PTNS weekly for 12 weeks, and they principally looked at the response. The non-neurogenics had a 78% response, but they had a very poor response rate in kids with neurogenic lesions. There are a couple of studies looking at the economics. There are really no large-scale cost effectiveness, cost utility studies. A lot of people refer to within these articles, which principally weren't economic studies, they're very sort of simple cost comparisons of PTNS to sacral nerve stimulation, but they're really not a full-blown, full-scale economic study. So I think that this is going to be to come, more information on that to come. So in conclusion, I think that PTNS does have some randomized trials, some level 1 evidence to support its use. It can be done outpatient in a minimally invasive form. Some of the disadvantages, well, you need to retreat and there may be need for maintenance. There are really very few complications. It's very well tolerated. And effectiveness, all of those studies generally report basically a 60 to 80% response rate when we're willing to use the definition of greater than 50% improvement. Thanks so much for your attention. We have about 5 or 10 minutes for questions.